Okay, today I got some really shocking information to share. Not too long ago, I saw on social media. I don't want to get into name dropping the different platforms, but I'm watching this post, and this guy says that he's doing really well. And I happen to know the guy, and I come to find out from other people that I know that the guy passed away. And so I'm like, what the hell? How the heck is this guy online posting that he's doing well? So basically, he died from cancer. And so I'm like, what is going on? Like, how does this even get out? And how is it, how are these things happening, basically? And when I started to look around, one of the things I realized is that this is like, the Wild West, in that people post all kinds of stuff online and there's zero accountability. In many cases, there's zero proof like what they say is even accurate. And it got me thinking about how many times I've read stuff online and it cannot possibly be accurate or true. And then you got all these people underneath going, oh yeah, I believe I'm going to do the same thing. And you're like, oh my God, did all of a sudden everyone that's in social media land, did they lose their critical thinking skills and just blindly accept every single word that someone tells them? Like, at what point do you say, hey, this is my life we're talking about. My life has value, and I'm not gonna just blindly accept something that someone posts online that doesn't know me, it doesn't know anything about my genetics and what's going on inside of my world. But unfortunately, it seems like a lot of people treat their health with the same level as if something like this. So if I said, hey, I went out to this restaurant last night and I had a really good meal, I recommend you try that. And they go, okay, I'll try it. Now, if they don't like it, they don't have to go back. But now we're talking about your life, like terminal condition or something serious like cancer. You want to have a little bit more attention and just like, hey, I might try it. It's not the same level of concern. And, the penalty for failing is death, versus if you go to the restaurant, you don't like it, you don't have to go back. And so what I wanted to do is kind of say, okay, how do we kind of bring in some critical thinking skills? How do we bring in some higher levels of discrimination to say, like, how do I know what I should do? And how do I know what I'm doing is even working? So the idea is to help each individual kind of get some personal accountability, what's happening like in their own body. And so what I kind of want to do is walk you through some steps that I found to be extremely helpful. And this is thousands of patients now. So first is a basic concept that it revolves around something called tumor heterogeneity. And the idea behind this is that, hey, there are differences within a tumor. So all the cancer cells are not the same. And what I'm going to add to that is that not only are the cancer cells not all exactly the same, but on top of that basic concept, we now have other concepts like intratumoral microbiome. We now know there's bacteria, there's fungi, there's viruses, there's other stuff in that tumor. And it could also be inflammatory molecules that draw fluid into that area. There could be other cells like lymphocytes and fibroblasts that are inside that tumor. So think of that whole mass, it's not pure cancer. So there's other factors that can determine the volume of that. And maybe a good way of thinking of things, if you had, like, say, if you had an injury and you had some pain in your joint, an orthopedic doctor could inject you a cortisol or maybe give you prednisone or even dexamethasone, but some sort of anti-inflammatory that has a systemic effect, or injected for local effect. And they could reduce inflammation on the spot. And you're like, whoa, my joint moves so much better. But they did not structurally change anything. Like, whatever damage was there before is still there. So we're surrounded by real world evidence that we could feel better, we could have an effect, but there may not be any structural change. And what I'm sharing with you today is that when people have a mass of any kind, the fact that it gets smaller does not mean that there's actual cell necrosis or cell death, or in this case, cancer cell death. There could be other possibilities explaining that. And why is that important? Well, because I'm seeing a lot of people, they just do imaging only. And so think of it as they got all their eggs in one basket as far as assessment. And now they come to find out that maybe the components that changed weren't the cancer components of that tumor. So for example, what if fluid just reduced? What if lymphocyte infiltration was reduced? Or what if the weaker cancer cells were killed, but not other cancer cells? So looking at this model from Sloan Kettering, it communicates that all the cancer cells are represented as gumballs. We used to think they're all one type, so they use white gumballs. And now we find out that there's differences in the cancer cells, and so they use basically 4 different colors, red, green, blue, and yellow. And imagine if you did a treatment, and that treatment wiped out all the green gumballs. Well, now the volume or the mass starts to shrink. And so now you say, hey, I'm winning the war. But what you don't see is that there's other cancer cells alive that are still there, and those cancer cells aren't actually responding to the treatment. And now once that, let's say, volume becomes undetectable by a scan, the imaging is indicating, hey, there's nothing here. But the reality is that you have cellular levels of cancer, not sort of tissue levels. And now there's something that can grow later on. So how do we kind of prevent this from happening in people, and how do we find out maybe more details that can help them make a better decision? Like, should you continue treatment even though the scan shows there's nothing there? Should you introduce other treatments that maybe because you have new details that you need something new to add to your arsenal to fight cancer? So what I'm going to do now is first show you this other slide here. I should say a web page, not slide. This web page is from a journal called Nature Reviews Clinical Oncology. And in this article, there's one key point I just want to make. And basically it says tumors with high levels of intratumoral heterogeneity might predispose patients to inferior clinical outcomes. And basically it's kind of like the scientific, politically correct way of saying, hey, this could be why treatments don't work. Because if you're targeting the green cancer cells, then what are you doing for the yellow, the red, and the blue cancer cells is basically the concept. And what tends to happen is there may not be a weapon against them. And this is why some of the times you hear things like people say, well, I'm doing treatment A for my cancer. And I'll say, well, how do you know that's working? And how do you know it's going to hit all the different cancer cells in your body? And usually I get, I don't know. Because no one ever took the time to look at the mechanistic details as far as the cancer in their body. They just read something online. They're going, oh, I'm doing vitamin C, or I'm doing hyperbaric oxygen, or I'm doing IPT, or I'm doing chemo, I'm doing radiation. They're doing something, and you're like, but where's the data from your body that helps you to determine that that's the right treatment for the cancer in your body? The vast majority of the time, people don't have any information at all that validates what they're doing is the best fit for them. They're essentially just doing what they read, and they pursued a doctor that offers it, or they're doing what their doctor told them, and they never took the time to ask the doctor, hey doctor, could you explain to me why this is the best treatment for what I have inside me right now? And then of course, if you looked at any of my videos, read any of my books, the second question you ask the doctor is, hey, what will you do when that doesn't work? That's another question people always forget. They always assume that everything they do works. Nothing works forever. The one thing we know from oncobiology is that cancer cells become resistant to treatments over time unless you have a plan in place to prevent that from happening. And so what I want to do now is kind of transition from, okay, we identified that there's differences within a tumor. And those differences require perhaps different treatments at the same time. But how do we know which treatments to do? Because if you don't want to do everything, because it simply doesn't work, because some treatments can counter other treatments, hence why doing everything doesn't work. So you want to make sure all the treatments you are doing, that they're aligned, they're going in the same direction, and that they don't interfere with each other. Otherwise, it's like paying money that you're going to also then throw that money away. And why would you waste effort? Why would you waste money when you don't need to? You want whatever you're investing in your health, you want it to actually go forward and produce a result, not produce a distraction or an interference to the outcome. And so what I did is I brought in here, this is a company, a lab called Tempest. And so what I like about Tempest is Tempest has a wide range of tests. We use this particular lab right now because they give us incredible details about the genetics of the cancer in a given individual. And what I see from, so let's say if I had 10 men with prostate cancer, 10 women with breast cancer, every single one has different findings. I don't see any two people out of 10. So 1 out of 5. I don't see any, no matter how you reduce it. What I'm not seeing is the same information. There may be common mutations, like you always hear about certain mutations, like, for example, now there's a common mutation like ATM. You sometimes hear about BRCA1 or BRCA2. Sometimes there are germline genetic mutations. That means the person was born with them. Sometimes there are somatic mutations, and that means that's in the cancer, but not in their germline. They're more born with it. And there's definitely some common mutations, but you see in conjunction with that, there's a whole bunch of other mutations that differ from person to person. And these differences make sense because every human being is different. So it makes sense that you're going to find different things when there's cancer in an individual's body that you cannot necessarily find in another individual's body. So we use Tempest because it tells us a lot of information. And then from that information, the lab actually tells you FDA-approved therapies. Typically, those therapies are covered by insurance. So it's a good, way to minimize expense if you have something that insurance would cover. It tells you other potential therapies, or sometimes it'll say like there's a mutation that's biologically relevant and there's not an FDA-approved drug, but there's a clinical trial that you can get involved with that may benefit you. So there's that information. And then it gives you variants of uncertain significance. And these are genes that there's no clear guidelines on what to do. And so what we do within our organization is we look at what's the function of that gene, what happens when there's a mutation, like is there a loss of function, is there a gain of function, and then we figure out what kind of ways can we potentially address that mutation through exercise and nutrition. And the reason is I've seen over and over again where the right combinations of exercise and nutrition can dramatically enhance results from people doing sort of FDA-approved therapies. And these are the reason why we have really good outcomes is because we're looking at a lot of facets of an individual's cancer. And that could produce results that would be difficult to get elsewhere because we have such a wide range of treatment options under one roof. And then around us, we have other centers that provide all kinds of other treatments. So we could sort of, as a group, when someone comes here, I could say, look, I really think you might benefit from this therapy that we don't provide, but I know some of the top experts in the area, and I can connect you with them. So that way now that individual gets like the best person to do that job, so to speak. And so we use Tempest because it gives us a lot of ideas in terms of helping people based on their DNA that's shed in the blood from the cancer. Now we use another lab. This lab is really good. It's called Billion-to-One. Their platform is called North Star. And the reason why I use this particular lab is they have 2 tests. One is called Select, and that tells us the DNA that's in the blood as well. And it lets me know then, okay, if I have different labs picking up the same information, or sometimes you pick up differences, because remember, the blood samples, it's different samples. And then I also I use these labs to do something called a response as a test, and lets me get a tumor methylation score and then compare how a person's doing over time. And basically, what I have found is that if I have a patient that's tumor methylation score is going down, they're doing really, really well. And I really like the fact that I could use this test to see very quickly if the overall treatment plan is working. And that way I can know that, okay, we're going to keep doing what we're doing because we're getting the expected results. Or right away, hey, this isn't working. We got to add some more weapons. We got to pivot and go in a different direction. And then I have 2 more labs. One is called Menarini, and Menarini has a couple of technologies, but one is called Cell Search, and Cell Search is used to find circulating tumor cells, and it can also pick up specific markers on these circulating tumor cells or CTCs. And one of the things we learned by using this lab is that a woman with breast cancer may have a HER2 positive or HER2 negative initial diagnosis. So let's say the original tumor mass was HER2 positive. The CTCs can convert, and then you see these circulating tumor cells are now HER2 negative in the blood, or they could be positive. So it'd be HER2 positive in the blood. The reason why that's important is kind of think of it this way: when you have the biopsy sample and it goes to the pathologist, and the pathologist says, "Hey, it's HER2 positive or HER2 negative." It doesn't matter the original diagnosis, but let's just say it's positive. Well, then obviously your oncologist is going to say, "Hey, I recommend this medication that's approved to treat the HER2 positive cancer." And that's appropriate. It makes sense. The challenge with that approach, though, is that as you have these isolated circulating tumor cells that go into the blood and they're HER2 negative, that medication, which makes sense to use, it can't conquer every cancer cell. Remember the Sloan Kettering, the colored gumballs. So think of it as like that medication makes sense, but it's only wiping out the green guys. It's not touching the red, blue, and yellow guys. And now you got a few yellow guys that are escaping. They're going to grow and form new cancer. And that cancer, those tumors, isn't going to get hit by the medication, even though the medication is the best tool for the original green guys. And so that's why there's some value in doing the cell search test. And then what Menarini also offers is something called the M-Search. And what I really like about the M-Search is it gives you 5 different sort of treatment categories or levels. And what's really useful about that is sometimes people have a mutation that's rare. And it's kind of like you see it and like, what does this mean? I've never seen this before. Like, it's not like there's a giant encyclopedia for every mutation ever discovered. There's some people have rare mutations and there's not much information on. You can go on the internet and search all you want. You're not finding anything. And so what is nice about Menarini is they could say, hey, this gene is in this category, and in this category, these are the weapons that have the best results. So what it tends to do is it tends to give a physician more options when there's not something that's readily available that's been approved by the FDA, or let's say someone has something rare, there's not going to be anything approved, right? Because it's rare. So now there's still a way to help that patient to get some results based on having more options for treatment. And then there's one other lab. Its lab is called Grail, and the test is called Gallery. What I really like about this test is that Gallery has, it's a very specialized test that picks up really difficult to measure cancers. And their test, kind of think of it is it's basically there's a cancer signal or there's not. So kind of think of it as like positive, negative, or pass, fail, whatever way you want to look at it. But we would consider it more of a qualitative test. What I like about this test is, let's say if I have someone with cancer, the way I would implement this test is I would run it on them, and if this test picks up their cancer, I now have a tool to pick up molecular evidence of cancer in that individual. So it's kind of like you would say, well, if I know I have cancer, why would I run a screening test to see if I have cancer? And the rationale is we're going to also validate that the test works for you as an individual. And now if we got, let's say, a PET scan shows you have cancer. We have the Gallery test shows you have cancer. And now we do treatments and the mass is shrinking on the PET scan, or multiple tumors are shrinking on a PET scan or CT MRI. That's wonderful. But how do we know there's no evidence of molecular cancer? You're not going to pick up cellular molecular cancer on any imaging methods today. So what we got to do now is have another test that we could use in conjunction. And sometimes, like, there's proteins in the blood that could be measured. But what I like about the Gallery test, if I used it previously and it was positive, I validated for that individual that it picks up their cancer. And now when I use it again later and their PET shows no evidence of disease and the Gallery test shows, hey, no cancer signal, we're now in a better place to say, hey, look, there's nothing showing up there. And that gives us more confidence that we got as much of the cancers could be measured and detected with current methods. So I hope, this information was helpful in that, like, just because somebody posts something online and says, hey, I'm beating, cancer, my masses are shrinking, that doesn't mean that all the details of cancer are been addressed and it's gone. Like, obviously it's good news when someone says, hey, stuff is shrinking. That's always better than stuff is growing. But in terms of so many people say I'm winning and then later on they die, and then you're like, well, how could that be possible? And what I hope to share with you in this video is that that's why, because they're looking at the big picture, and that big picture doesn't give you the really small details. So if you or someone you love has got cancer or got some other health condition that's pretty serious, please reach out to us. There's a form below this. Just fill it out and let us show you why we're rocking it right now. We're helping all these people from all over the world, and we're having fun. There's no one crying at our center. You got people laughing and having a good time, because not only are they beating disease, they're looking good. They're getting muscle, they're losing fat, and they're able to do things they haven't done in some cases in 20 or 30 years, because they're not just winning the war against the disease, they're actually improving their overall health in every area, from their brain to their heart to their lungs to the immune system to their joints, and getting rid of cancer at the same time. Thanks.